Great. So yeah, thanks very much for the introduction, Luke. So I'm Simon Johnson. I'm a respiratory physician, and I run the UK LAM Center, which is an NHS-funded clinic for patients with LAM in the UK. So we're funded to see everybody in the UK with LAM, including people with tuberous sclerosis and LAM. So what I'm going to cover this evening really is what LAM is. Very briefly, in general terms, how LAM gets diagnosed, how we assess LAM to assess the severity, and a little bit about treatment. So I did do one of these evening presentations a few years ago, so a little bit of that will overlap, but I think it's worth refreshing that. But then there's some new stuff this time on a little bit about the UK LAM Center, the clinic that I run. We've recently looked at the features of everybody with tuberous sclerosis who's been to the LAM Center, so I'm going to give you a little bit of data on that, and hopefully there's a couple of important messages there, and then hopefully we'll have time for questions at the end. So I'm going to start off really by talking about how big a problem LAM is for people with tuberous sclerosis. And for children with tuberous sclerosis, it's not really an issue. It's one of the features of TS that comes on a specific age, and really tuberous sclerosis, LAM in tuberous sclerosis really only affects adult women. It occasionally occurs in men, but because we think the disease is driven by estrogen, men don't tend to get progressive symptoms, doesn't really cause them any problems. So really the key audience for this talk will be the adult women with tuberous sclerosis. So it's a reasonably common problem for women with TSC. So it gets more common as you get older. So at the age of 20 years, if we looked at every woman with tuberous sclerosis, about 1 in 10 of them would have some evidence of LAM. By the age of 40 years, half, maybe more of all women with tuberous sclerosis would have some evidence of LAM. So as we're getting better at looking after children with tuberous sclerosis, and there are more adults with TSC around, and we're getting better at identifying TSC in non-classic cases, LAM's becoming more of an issue for the tuberous sclerosis community. So hence talking about it this evening. Perhaps the most important thing for people to take away from this today is that LAM is a very variable problem. So like most symptoms in tuberous sclerosis, it can affect you quite significantly, but for some people they can have the problem and they have no symptoms at all, and actually that's really quite common, that it doesn't cause any clinical problems. So but it's worth talking about, because even if you have a mild manifestation of LAM, there are things we can do, and for some people it can progress and cause significant issues. So how do we diagnose LAM? Well, the majority of people at the moment get diagnosed with LAM after they develop lung symptoms. So that might be breathlessness. Occasionally it presents quite acutely with pain in the chest. People get assessed by their doctor and they found that their lungs collapsed. And this is a relatively common presentation in people with LAM. Sometimes it's found really by accident. So when people are having tests such as kidney scans, site of the lungs, you can see evidence of LAM. And sometimes people have scans for completely unrelated problems, and LAM's diagnosed that way. What should be happening actually is that ever since 2013, when we wrote these new international guidelines for how to manage and look after people with tuberous sclerosis, we recommended that everybody with women with tuberous sclerosis should have a CT scan of their lungs at the age of 18 to see if they have LAM. So this is called screening. So the guidelines say women with LAM at 18 should have a CT of their lungs to look for LAM. If they missed it at 18, they can have one as soon as this becomes relevant for them. But actually, I'll show you some evidence later that really not enough screening for LAMs being done in people with tuberous sclerosis. So most patients at the moment, breathlessness, lung collapse, or sometimes they have a scan for another reason, and LAM gets diagnosed. So the best test for diagnosing LAM is a CT scan. So the CT scan is an X-ray based scan, and this little cartoon represents a patient in a CT scanner. And the CT scanner is like a giant polo mint. It's not the sort of tunnel-like scan. That's an MRI scan. It's not particularly noisy. You can do a CT scan of the lungs in LAM in about a minute. So it's really quite a quick and easy test, and not particularly unpleasant for people who get claustrophobic in MRI scans. So the picture that's on the screen is a section of a CT scan. So when you have a scan, you're lying on a table, and the table would be at the bottom of the picture. And so the bottom of the picture is the patient's back, and I've labeled the spine, the backbone down at the bottom of the picture. The heart's at the front of the chest, which is towards the top of the picture. And then the two big grey sort of half moon-shaped areas are the lungs. The background grey colour is normal-looking lung tissue. The little white things are blood vessels, so those are normal. The black circles, some of which I've highlighted with these yellow arrows, those are lung cysts. That's area where the lungs become damaged and disappeared, and that's the hallmark of LAM. So when we see that in somebody with tuberous sclerosis, we can confidently diagnose LAM. We don't need to do any other tests. And so the CT scan really is the best way of determining whether you have LAM or not. So I'm going to talk a little bit now about the main symptoms related to LAM. And as I said, very often there may be no symptoms at all. And actually, I've done my LAM clinic today, this afternoon. I saw a new person who has tuberous sclerosis. She has a little bit of LAM on her CT scan. She has no symptoms at all. She's not breathless. She's completely well. And she's never had any of these things, and that's quite common. If your LAM is more significant, then you can get shorter breath. If one of the lung cysts that I've shown you on the CT scan bursts and air leaks out of the lung can collapse down, and that can cause a pain in the chest, and that's what we call a pneumothorax. And some people with LAM are prone to cough, and some people occasionally cough up blood. It's not usually a worrying thing. It's just a feature of the disease. Some people cough up chyle, the fluid that runs in lymphatic tissue, and I'll talk about that a little bit later. And some people are more prone to respiratory infections and cough because of that. So I'll talk about these main symptoms in a little bit more detail. So the main issue with breathlessness is it usually happens when you get more lung cysts. So this is another CT scan, and you can hopefully spot the black circles now, which are the lung cysts. This person has a few more cysts than the one I showed you before, and they will probably be breathless when they say walk up hills or stairs. And everybody gets breathless sometimes if they do something strenuous, but the sort of breathlessness that you might be concerned about is breathlessness that starts to come on and gets worse over time. So you might notice that you're breathless on hills, and then you might notice you're breathless if you walk quickly on the flat. And so if you have this progressive type of breathlessness, that may be a symptom of LAM. As LAM progresses, for some people, you get more cysts. So this is another CT scan from another person who's got more significant LAM. So you can see a lot more of the cystic spaces on this scan and a bit less lung tissue. And this person will be more breathless than the person before. As time goes on, for people with active disease, this little chart here, each one of these arrows is a person with LAM. These are mostly people with sporadic LAM, but similar for tuberous sclerosis. These little arrows are change in lung function over time. And see some of these arrows point downwards. The longer ones show that lung function is changing quickly. The short ones show that it's not changing very much. So you have a mixture of changes. So for some people, the cysts in LAM can accumulate and make them breathless over time. As I say, that happens for some people, not everyone. The dramatic thing, and the thing that a lot of people get concerned about is pneumothorax or collapsed lung. And the chest X-ray I've put up here is of a woman who suddenly developed a pain in her right lung. Doctors put X-rays always look the wrong way around. So the right lung is on the left of the X-ray, the left lung is on the right of the X-ray, and I've shown you where the heart is in the middle there. So this X-ray, the left lung, you can see it looks quite hazy up and down the lung field. So that's because the lungs there expanded, that's normal. The white arrow on the right side, that bit of the chest is quite dark, and that's because the lung's not there. And the lung in this case has collapsed down. The blue arrow is pointing at the right lung, which is completely collapsed. And this is because air's got around the outside of the lung. And you can see it quite nicely on this CT scan. You can see on the left side, well, on the left lung, the right side of the picture, the lung's expanded and fills the whole of the chest on that side. Whereas the arrow points to a big air gap between the lung and the chest wall there. So when this happens, if the air leak is quite small, you might not need any treatment, and it will heal up on its own. Sometimes you need to put a little needle into the airspace where the arrow is and draw the air out. And sometimes if there's a big leak and it's persistent, you need to put what's called a chest drain in. And the little cartoon I've got on the left side of the slide here shows the collapsed lung and this little the chest drain going into the space where the arrow is on the CT scan between the lung and the chest wall. This allows the air to bubble out underwater, so air can't get back in, and this allows the lung to expand. Some cases the chest drain doesn't work, and some people sometimes need operations to have pneumothorax fixed, but that's unusual. So that's pneumothorax. This X-ray shows a pleural effusion. So a pleural effusion is when fluid builds up around the lung. So for patients with LAM, the lymphangio bit of lymphangioleiomyomatosis, the whole name for LAM, which I'll try not to use too often. The lymphangio bit means that the lymphatic system can be affected by LAM. So the lymphatic system is a series of little tubes that run next to blood vessels. You don't know they're there normally. They collect fluid from your subcutaneous tissue, and they also they absorb fat from your diet. So the lymphatics are full of a sort of milky type of fluid called lymph or chyle sometimes. And in LAM, if the lymphatics get blocked, the lymphatic fluid comes out of the lymphatics around the lung. So this is a CT scan which shows that a little better. So you can see this is a CT scan taken from the front of the patient. So the heart's in the middle here. You can see the little cysts in the lungs, and the white arrow is pointing at this pleural fluid that's built up, and that squashes the lung, and that can make you breathless as time goes by. Sometimes the lymphatics in the abdomen are also normal, and I'm showing you this particular picture because the yellow arrows are pointing to some enlarged lymphatic tissue in this person's abdomen, and that can sometimes cause bloating and other features. So these are effects where the lymphatic system is involved by LAM, and it can cause fluid to build up in the lungs and the abdomen. This is quite unusual. This will happen to about 10% of people with LAM generally, probably a bit less common in people with tuberous sclerosis. So if you have LAM, the first thing we want to do is assess the severity. And obviously we've talked to people who don't really get very breathless aren't going to have severe LAM. When we look at scans, if there's lots of cysts, then that's likely to be more significant. If there aren't very many cysts, like most of the scans I've shown you, then that's going to be a mild problem. We can be a little bit more precise in that, and we can test people's lung function. So we do two separate groups of tests of lung function, really. The lungs are a selection, a lot of branching tubes which take air from the atmosphere to the alveoli. The alveoli are little sacs that you can see in the picture I put up here. And they take oxygen into the bloodstream from the air, and they remove waste carbon dioxide from the body. And then that gets breathed out. So the alveoli are the gas exchange bit, and the bronchioles are these little tubes that take air down to the alveoli. Both the airways and the alveoli can be affected by LAM. And as LAM gets worse, the airways can become narrowed. And we do that by measuring a test called the FEV1. And that can also reduce how efficiently you get the oxygen into your bloodstream. So we do a test called a gas transfer or DLCO test to measure that. And these things are slightly separate. For those of you who haven't had lung function tests, they're slightly hard work because you have to breathe in and out quite forcibly. But the picture at the bottom shows somebody doing some lung function tests where you breathe in and out of a few machines. The whole thing takes about 25 minutes. And when we've done that, we can assess how significantly the lungs have been affected by LAM. The other thing that we're interested in is how much oxygen you get in your bloodstream. That's a lung's main job, really. And you can now get the little oxygen meters all over the place. You can buy them in Asda for £10 or so, and that measures how much oxygen's in your bloodstream. The little picture I put up here, each one of these little dots that you see here is a person with LAM that we've seen at our centre, and this is their oxygen saturation when they're sitting resting. The normal is just over 95 here, this green zone. This is the OK zone, the white area. And then this is more abnormal when you get below the high 80s. It's helpful to measure people's oxygen levels, but it's more helpful to do it when they're exerting themselves, because our standard lung function tests just measure what your lungs are doing when you're resting. But when you put them under stress by getting people to walk, and what we've done here is walked all these people up and down the corridor outside the LAM Center, and you see for most people, their oxygen level after the walk is not too bad. But for some people, it drops down quite significantly, and this suggests that their LAM might be significant and they might need different treatment. So we do all of these different tests to assess how significant the LAM is. If you have LAM, we usually, depending on how significant a problem it is, we will see people perhaps every 3 months when we're doing lots of things with them and keeping a close eye on things. If everything's quite quiet and under control, we'll perhaps only see people once a year. And we'll do breathing tests, so the FEV1 and the gas transfer test at each of those visits, and we'll assess what their breathing symptoms are like. And in between times, if people have complications like a chest infection or maybe a pneumothorax, one of the collapsed lung things I've told you about, then we'll see them as necessary. So I'm just going to talk a little bit about treatments for LAM. So quite often people with LAM are prescribed inhalers. So this picture I put up here is a young woman using one of the standard asthma inhalers, the salbutamol, the blue inhaler. If you've got narrowing in your airways due to LAM, then inhalers like salbutamol are quite useful and can improve your symptoms. If your lung function is normal, they probably won't help you at all. What we commonly use now are a better type of inhaler. So the salbutamol, the blue inhaler, lasts about 4 hours. You have to take it frequently. We now have inhalers that last all day, and you take them once in the morning. You don't have to carry around. You can forget about them. They have 2 drugs in. These are called LAMA-LABA inhalers, and we use those quite commonly for people with LAM who've got airway narrowing. We find they're quite good for improving breathlessness. They don't completely reverse the problem, but they help symptoms. The most important treatment for LAM are mTOR inhibitors. So sirolimus and everolimus are mTOR inhibitors. And the graph I put up here is from a study called the MILES trial, which was the big breakthrough for people with LAM, both the tuberous sclerosis associated form and the sporadic form. And this was a trial of sirolimus or rapamycin in LAM. And what this shows is that they took nearly 100 patients with LAM, and half of them got a placebo, a dummy tablet, half of them got the active drug. The white bars are the people, the change in lung function over 1 year in people given the placebo. So these went down fairly significantly. The filled bars here, you can see they actually go up a little bit. So the patients who took rapamycin, they didn't lose any lung function. In fact, it improved a little bit. And so this showed us that sirolimus rapamycin could protect people's lungs against LAM. And now this is the treatment we use for people with active disease. What's important to appreciate, as most of you probably know, actually, that mTOR inhibitors also reduce the size of angiomyolipomas. So we tend to use sirolimus for the lungs and everolimus for the kidneys, but actually they both work for both. The other thing that mTOR inhibitors are really useful for are the chylous complications that I showed you. Those used to be really difficult to fix before we had those, but now they're very treatable with these types of drugs. For some people, if LAM gets quite advanced, or if their oxygen level falls a lot when they exert themselves, then we sometimes use oxygen therapy for people with LAM. That's pretty unusual for people with tuberous sclerosis, though. Most people don't need that. And of course, there's lots of research happening into better and new treatments, both for tuberous sclerosis, but also for LAM. So at the moment, we have all of these treatments, and hopefully we'll have new things coming online over the next few years. So if you're thinking, well, should I be on drug treatment for my LAM? How do we make that decision? Well, the first thing to look at is how bad your LAM is. So we look at the lung function test, so the FEV1 test, the gas transfer test. We look and see what happens to your oxygen level when you exert yourself. Does it fall a lot, or does it stay normal? And then we look at your scan and see how many cysts there are in the lung fields. And we put these together to get a sort of idea of how significant the LAM is. And then, of course, we have to look at you. You're not just a pair of lungs, you're a person. And so young people and older people are affected differently by LAM. You may have other LAM issues. So if people have bad kidney problems, they might have an mTOR inhibitor anyway, which will also treat their lungs. We look at other factors. We look at the rest of your medical history and how bad your symptoms are. And so we put all this together to work out really how the disease is affecting you as an individual, not as a sort of overall thing. So the bottom line really is, if you're concerned about LAM or you have LAM, you need to discuss your symptoms and your test results with your specialist. It's not everybody with LAM has to go on sirolimus. If you decide to go on to treatment, then you have to understand the risks and benefits, by which I mean what the drug's likely to do for you, which is hopefully stabilize your lung function, but also the side effects and other things. And there are side effects from sirolimus. I don't really have time to talk about all those tonight, but for most people, we can make that manageable, and the side effects aren't too bad. So there are things you can do yourself. The first thing is, it's helpful to know if you have LAM. So if you're a woman over 18 with tuberous sclerosis and you haven't had your lungs scanned, it will be sensible to get that done. And so I would talk to your tuberous sclerosis doctor about that. It's helpful to be informed about the disease. Of course, everybody here is doing that just now. And so knowing what the symptoms of pneumothorax are, understanding that if you get chest infections, you should go and see your GP promptly, making sure you're up to date with vaccinations against the flu, against COVID, and against pneumonia. And also, because LAM's a disease of women and affected by estrogen, pregnancy can affect LAM also. So if you're thinking about pregnancy, it will be sensible to talk to us about that, so we can give you the right advice about LAM for your pregnancy. And of course, in women with tuberous sclerosis, excuse me, there's a genetic issue also. Keeping fit and active is also really helpful. And you can do that yourself, but there are also programs for people with lung conditions called pulmonary rehabilitation, which your local lung doctor and sometimes GP could refer you to. It's also there's a couple of things that you shouldn't do. So I've already mentioned that estrogen's bad for LAM. So it's best to avoid the combined contraceptive pill that has estrogen in it. The progesterone only pill is safe to take. But it's just the combined pill that we recommend people don't take in most cases. And if you've been through the menopause, then it's best to try and avoid estrogen containing hormone replacement therapy as well. But that's, again, a slightly individual decision. And of course, nobody really should smoke cigarettes. And we always discourage that. So if you do have a screening scan and you don't have LAM visible on the scan, that's on the whole good news usually. As I've said, it gets more common as you get older. So if you don't have LAM on your scan, you may get it later. That's the older you get, the more likely that is. It's a little bit more likely if you have a TSC2 mutation rather than a TSC1 mutation. And there are various guidelines. There's a UK guideline that we all wrote, and there are the international guidelines that we contributed to that suggest that at each clinic visit, everybody with tuberous sclerosis should have potential symptoms of LAM checked. So really people asking about shortness of breath and other lung issues that we've discussed. And we should probably repeat the lung scan between every 5 to 10 years. You don't want to do them too often because they're an X-ray scan and lots of X-rays aren't good. But every 5 to 10 years is probably sensible. If you get symptoms that might suggest LAM, then you should have one then. And of course, I've already mentioned that you should avoid smoking and the estrogen-containing pill. So that's a sort of very quick overview about LAM. So I'm going to just spend the next 10 minutes or so talking about the clinic that we run. It's an NHS service. It's funded by highly specialized commissioning. So that's a little bit of the NHS that deals with rare and unusual conditions. So they fund us to run a national service for people with LAM. So you can get directly referred from England, and we'll see people from anywhere, but sometimes we have to get approval to see people from Wales. But if you are in Wales or Scotland, don't worry, we can see you if you want to come. We've evaluated about 400 plus women with LAM. So the majority of those people have the form of LAM that's not associated with tuberous sclerosis. It behaves in the same way. It's called sporadic LAM. And those patients also get kidney angiomyolipomas, but they don't have tuberous sclerosis. About 70 of the patients we've seen out of that 400 are people with tuberous sclerosis related LAM. In fact, I saw another 2 today, so that's continuing to go up. So the service, the core service runs in Nottingham. So as I said at the start, I'm a respiratory doctor. So it's a mostly respiratory service, and there's myself, Dominic Shaw, Gauri Saini, and Saijin Chong, who are the doctors there. And then we have Holly, Shannon, and Alison, who are our nurse specialists. And we have Wendy, who runs the service. And if anybody's been there, they know that when they go, they have their breathing tests on the same day. If they need a scan, that's on the same day. If they've had tests, we've got the results there. And that's because Wendy sorts all of those things out. We have a link with Jacqueline Eason, who's a genetics doctor who is an expert on tuberous sclerosis genetics. We have links with the thoracic surgical people if people need operations for pneumothorax or other things. We have a link with the Mr. Batt in Birmingham, who looks after most of our angiomyolipoma work. And also we have a link with the lung transplant service. Although since we've had rapamycin, we don't seem to need them so much, which is good news. And of course, because we're just one centre in Nottingham, which is, although it's in the middle of England, it's a long way from a lot of places. So we work closely with people's local doctors, so we don't have to inconvenience them by getting them up to Nottingham too often. And really the aims of the centre are to make a diagnosis, an assessment, and provide coordinated expert care throughout the journey from diagnosis to treatment, and follow up after that. We'd like to coordinate things at one place, so we reduce the burden of appointments. So we try and do all the scans and tests all on the same day. And we like to think that we give good care according to current guidelines. The other thing that we do at the LAM Center is that we do quite a lot of research there. So I'm going to talk a little bit about the features of people with tuberous sclerosis that we've seen. And this little pie chart here is the first symptom that people had of LAM. And so you can see that common things are breathlessness and pneumothorax. The most common way that people got sent to us was because they were having their kidneys looked at for angiomyolipoma, and LAM was spotted, and then we were referred the patient. Only 1 in 5 of the patients actually had a screening CT like they were supposed to, and then got sent to us then. And so this really suggests that, you know, not enough people are having screening for LAM. By the time, if you come and see us when you're already breathless or you have other problems, that may mean that your disease would be a little bit more advanced than had we detected it by screening when you were younger. And so that's a bit of a missed opportunity. So we've really got to improve screening for LAM and tuberous sclerosis, I think. This little graph here is the number of new referrals to our service. So the light grey line is the number of referrals per year for sporadic LAM, and then the black line at the bottom is for people with tuberous sclerosis. So you can see where this dotted line hits here. This is 2013 when the guidelines started saying you should screen everybody for tuberous sclerosis, for LAM when they have tuberous sclerosis. What should have happened then was this black line should have gone up as we detected more cases. But actually, as you can see, it's sort of just bobbled along at roughly the same number every year, give or take. So I think we need to work a little bit harder to make sure people with LAM, people with tuberous sclerosis get screened for LAM. So the other thing that we're sort of interested in is the other features of other tuberous sclerosis features of people that we see with LAM. The people with tuberous sclerosis LAM are slightly different from the average person with tuberous sclerosis, if there is such a thing as an average person with tuberous sclerosis. But what we did here is we took this TSC registry. So the TSC registry is a research registry with over 2,000 people with tuberous sclerosis, from children to adults. And so it's a very big cross section. And Dr. Kingswood, who I guess most of you know, was the lead author on this. So we compared the people we see with the people in the TSC registry. And in these slides, the black bars are people with tuberous sclerosis and LAM that we see, and the grey bars are people with tuberous sclerosis who are in the TSC registry. And the first thing to say is, so in the TSC registry, most of the people got diagnosed with tuberous sclerosis. These are the averages, obviously there's a variation, at about 1 or 2 years of age. Our patients, it's 18, and actually a third of all 75 patients that we looked at here got diagnosed with tuberous sclerosis as they were adults over 18, and 6 of them when they were over 40. So that's somewhat unusual and suggests that the manifestations of tuberous sclerosis might be a bit different in the people with TSC LAM. This is a little bit more data here. You can see that all of our patients with LAM are women, 100%, whereas half of people in only half of the people in the registry are women, or the rest are men, but no men. We've not seen any men with LAM at the LAM Center. It's more common to have TSC LAM if you've got a TSC2 mutation than a TSC1 mutation or an unidentified mutation. Epilepsy, learning difficulties, SAGAs, the brain tumors are less common in people with LAM than people without LAM, and this might be because people with those problems are a bit less likely to get referred up to the LAM Center. But it does look like the patients with LAM are a slightly different group of people. Nearly all of them have kidney angiomyolipomas. So for people with angiomyolipomas, the chances of them having LAM is really quite high. The other thing to say here is that the TSC registry, they think only about 8% or so of people with tumor sclerosis have LAM. That's probably an underestimate based on research, and it suggests that perhaps people aren't being screened very frequently, and so we need to sort of focus a bit on lung disease in adults with tumor sclerosis. So the first when we saw people at the LAM Center with TSC LAM, they were on average of 39 years, and they'd had their first LAM symptom just over 30 years of age. Lung function was a little bit reduced, not too severely. About half of them had a pneumothorax, and a number of them had needed an operation to fix that. As I said, nearly all of them had kidney angiomyolipomas, and nearly half of them had needed either an embolization or some sort of surgical treatment or an mTOR inhibitor for those. A smaller number had the lymphatic complications. That's a bit more unusual. So as I said at the front of the talk, not everybody needs treatment with an mTOR inhibitor. So of our 70 odd patients, about half of them didn't need treatment with an mTOR inhibitor. Over a third of them got treated with sirolimus for LAM, and a smaller number got treated with everolimus for their kidney angiomyolipomas. So the good news about this is that the people's lung function once they were on an mTOR inhibitor was markedly better than when they weren't, if they had active disease. If you don't have active disease, there's no benefit. But what I've shown here, I've highlighted with a little red circle. This is the change in lung function as time goes by. So over a year, your lung function, if you don't have LAM, just because you've got a year older, will drop by about 20 milliliters. The people with TSC LAM here, that dropped by 81 milliliters, so about 4 times as fast as due to normal aging. And the gas transfer dropped a little bit too. For when we put people on these drugs, either everolimus or sirolimus, the FEV1 change was only 3 mL, so better than due to aging. So the and the gas transfer actually goes up a little bit. So the drugs are very effective for LAM if it's active. If you don't, so that's been very good news for us in the community, I think. So if you're sitting there thinking, well, should I go to the LAM Center? Everyone's welcome, but not everyone needs to come, I guess is the message. So if you're thinking, well, I need to be screened, you can have a CT lung scan at any hospital. Everywhere's got a CT scanner, usually more than one. And anyone can really order that. And then an X-ray doctor will look at it and report and say there's LAM or there's not LAM. And so you don't need to come all the way to Nottingham to have that done. Your local team can do that for you. If you have a scan and they see that you have very mild disease, so just a few cysts, lung function's good, that probably won't ever progress or cause you a problem. Doesn't need treatment with sirolimus. All we do for that is we advise people about the risk of pneumothorax, what to do if they feel their symptoms are changing, they're getting more breathless, tell them to avoid medicine with estrogen in, and we give them advice about keeping healthy, which probably most of you try to do anyway. So usually it's not necessary to see us for that. If you have more significant disease, if you're breathless, particularly if your breathlessness is getting worse or your lung function's reduced, or there are any sort of slightly unusual features, then you should see a LAM specialist. That's normally the LAM Center. Some areas like London, there are LAM specialists around there too. So you may not have to travel all the way to Nottingham. But we're, as I say, we're here to look after people with LAM, including people with TSC LAM. So in summary then, I've told you that LAM occurs in the majority of women with tuberous sclerosis as they get older, but usually it's quite mild. For some people, it can be a problem, but for most people, it doesn't cause too much trouble, and you need to be evaluated individually. I think there should be more screening along we wrote the guidelines quite a long time ago, and that's not really, doesn't seem to be implemented particularly well. So people should get screened for LAM to avoid delays in treatment that could make lung problems worse. And the treatments that we do have are quite effective at suppressing the disease, reducing lung function loss, and other tuberous sclerosis related problems. So that's all I'm going to say, really. Thanks very much for watching. Very happy to take questions that anybody may have.
Thank you. Thank you, Simon. That was excellent. I've been scribbling everything down as quickly as I can. So useful. Yeah, it's wonderful. Yes, as Simon said, if anyone has any questions right now, please do either write them in the chat or put your hand up. I can see that there's one question here in the chat which I'll read out. So my 19-year-old daughter has just been screened. Results show multifocal micron. Well, I can't read all that.
Hyperplasia.
Yeah, all the nodules are measuring less than 4 millimeter, except for one that measures 2. So should she be screened again before the 5 years?
So micronodular pneumocyte hyperplasia is another feature of tuberous sclerosis lung disease. The little nodules are visible on the scans. They don't usually cause a respiratory problem. They don't usually cause symptoms. To most lung doctors, nodules are a little bit of a concern because sometimes suggest other things. But these types of nodules are different. You don't usually need to do anything about those. If there are a lot of them, we sometimes do repeat the scans from time to time, but not too often. I'm imagining your daughter doesn't have any respiratory symptoms particularly, or shouldn't do from just having the nodule. So it's usually something that just can be monitored in terms of symptoms. Occasionally, if there's lots of nodules or the nodules look like they're large, then we'll sometimes repeat the scan. But that's quite unusual, and so it's an individual thing. So I'll talk to your chest doctor about that to be sure, really.
Thank you, Simon. So the question I can see from Mary is whether it's a CT or a HRCT.
Okay, so in the old days, we'd always say do an HRCT, which stands for high resolution, so it shows the lung in detail. Most CT scanners now are so good that they all give you a high resolution image, or you can do an ordinary CT and you can turn it into one. If the X-ray doctors can. So any CT of the lungs is good enough to diagnose LAM. The high resolution ones, there's a little bit of a technical difference about how much X-ray you get and things like that, but any CT is okay really nowadays. It used to be more of a problem, but now it's anything will be fine.
Great, thank you, Simon. Very, very clear. So Carol, we'll go to you next, and then we'll go to Gail afterwards. So over to you, Carol.
Thank you, Simon. I thought that was really interesting and incredibly positive, actually. We've moved on so much in the last few years. I know you're a great friend of the Tuberous Sclerosis Association, and I wondered if you had any advice for those individuals who might find being screened or tested, having CT scans difficult. You showed, an illustration of somebody breathing into a machine, for instance. You know, I just wondered how you manage to screen and test those that might have some behavior challenges.
Yeah, so this is a really important question, and you're absolutely right. Not everyone can do lung function tests very easily, and to get the best out of a lung function test, you have to do it just right. People who on the call who've done these, you probably, you know, they're often the technician will, you know, repeat it and all these sorts of things. So that is an issue. So if what we usually do in people who can't do lung function tests, what they usually can do is we can measure their oxygen level with one of the finger probes. Most people are fine with that. And we can also, for most people, not everybody, I accept, get them to walk up and down and see what happens to their oxygen. So if you've only got a small number of cysts on your scan and your oxygen doesn't fall with exertion and you don't have too much in the way of symptoms, we can usually leave that be. In terms of looking at how that changes over time, we do tend to end up doing more CT scans in people who can't do lung function. So we look at the number of cysts. For people who are good at lung function, we usually just do that after the first scan, because then we don't have to expose the person to so many x-rays. So yeah, so there's ways around it. It's not quite as precise or as ideal, but yeah, that's what we have to do basically.
Okay, thank you.
Thank you. Good question. So Gail, will go over to you now for your question, if you'd like to unmute yourself.
Okay, it says tap to speak. I tried to unlock the video, but I don't know how that works.
We've got you. Can hear you.
Can you see me? You can't see me though, can you?
No.
No, I don't know how that works. I'm just wondering, are there any other specialities that doctor-wise that know about LAM? Sadly, my mum passed away in June. My brother has TS. Obviously it's genetic. My mum never had the genetic testing, but we know 99.9% sure that she had it. Now, she had bowel cancer. That didn't kill her, but she had bowel cancer. And she was in hospital from April till when she died in June. And they questioned metastases on her lungs. And I said, no, they're not metastases. There's something called LAM. And the consultant, the endocrinologist, took me aside and she goes, I agree with you. She said, how do you know about this? So I was wondering, do other specialities know about these different lung conditions and things?
Well, not normally. The trouble is LAM's a fairly rare condition, and so not many medical specialities come up against it, and so the people who know about tuberous sclerosis tend to know about LAM. So, for example, I work in the kidney doctors I work with in Birmingham, things, they know all about LAM, and they, you know, they sort of could look after it probably without too much trouble. But a lot of other doctors don't. I mean, the thing to do is really to signpost people to resources. The LAM Center has little cards that we give out saying what LAM is and giving a little reference for people to give to doctors if they, you know, if they say, oh, I've got LAM, and they go, what's that? Just to sort of signpost them in that direction. It can be a problem. Yeah.
I found that it was a problem because I was adamant that it wasn't secondary cancers, that it was this LAM, and she said, I'm very interested, and I said, well, we think my mum has this, and she was looking into it. I just, like you say, it's down to the people that it affects or the families that it affects to make sure other specialty doctors know when your family member or are in hospital, you know. But so she died from an upper gastric spontaneous bleed.
Oh gosh, I'm sorry to hear that. That's unpleasant.
Is that to do with lungs or not?
No.
No, gastric, she
Yeah,
middle.
that's the sort of esophagus, stomach, that sort of thing. So.
Yeah, well, thank you for clearing that up. Thank you. I'm going to try and make people more aware of TS. Really, that's my aim. Really.
That's what we like to hear, girl. Thank
I know.
you. Thank you for your question.
No, thank you.
So we've still got a few, and swear at the time, but let's see. We'll see how we get on. So there's one from Gemma here for you, Simon. Is there a correlation between asthma, LAM? So it's taken Gemma a very long time to finally get a diagnosis of TSC. So if there's any correlation between the two.
So this is a bit tricky. So a lot of, if young people start to get a bit short of breath when they exert themselves, often somebody will think it's asthma, because 1 in 10 people have asthma. I mean, it's a super common thing. And so if you treat everyone for asthma, you're right most of the time. But of course, we know that not all lung diseases are asthma. And a lot of the patients we see with LAM have an asthma diagnosis for years, and until the penny drops and they have a lung scan. So the first thing is it really asthma? The thing that makes it all a little bit more complicated is that one of the tests for asthma is to see if your airflow test changes after you've had one of those inhalers. And some people with LAM that have the change after the inhaler. That's why the inhalers work when they don't have asthma. So it's a slightly technical thing. So I'm not sure if the question is, do I have asthma because I have LAM, or I'm a bit breathless and wheezy and I've been told I've got asthma? Could it be LAM? The answer to both of those things is possibly yes. But LAM and asthma are separate diseases, but the two things can look very similar is the issue. And so but it's hard to do it without doing tests and talking in detail.
And I'm going to go over to you, and then I'll go to Sarah afterwards.
Hello, everybody. I have a question. My daughter is 45, and we didn't know she'd got LAM, like you say, until we had some investigations on her kidneys. They doesn't seem to be causing her any particular problem, but she can't do a lung function test at all, and she's in a wheelchair, so she doesn't exert herself, and there is no way she can walk anywhere. So how do you deal with someone? The last thing we did was to have an X-ray, and I think that's just looking at the nodules to see what's there. Any thoughts on that?
So if your daughter's 45, and am I right in thinking she doesn't get short of breath?
Yes, that's right.
Okay. So really, if we the main questions, I guess, are, does she need treatment to stabilize the LAM? If her symptoms aren't getting worse over time, and there's been, I guess, a fair amount of time for her symptoms to change if they were going to, that's a reassuring thing. We could, or they could, repeat the CT scan to see if there are more cysts now than there were. You'd need to leave it a while, a year, 2 years. You can't, there's no point doing it very frequently, because the LAM progresses fairly slowly for the majority of people. So, and the other thing is your daughter on treatment for kidney angiomyolipoma?
Yes, she is. So
she's on everolimus. Okay, so that will stabilize her lungs anyhow. So, I mean, obviously there might be little nuances, but from what you say, it sounds like her LAM might be mild. She's already on the treatment for it. And so I suspect you, from the lung side of things, not likely to progress too much. So I guess the main way you would follow that would be to repeat a CT scan. I personally, if someone's already on the treatment, they don't have any symptoms, I'd only do it if something changed.
Right.
And I'd probably park the whole LAM thing and just not worry about that too much unless something changes, in which case then I'd repeat the scan.
That seems very sensible. Thank you.
So there's going to be two final questions. I'm going to combine them together because they're both from Casey, and then I think we can call it a wrap from there. They're both quite different questions. So the first one, can LAM be more progressive when combined with other progressive issues? So I'm taking that as meaning if you've got other issues that are progressing, will that therefore lead to LAM progressing and vice versa as well?
We don't really know why some people's LAM progresses faster than others. We know that LAM usually progresses a little bit more slowly after the menopause. We know that the older you are when you get diagnosed with LAM, usually the more slowly it progresses. I'm not. If you mean, if the question is, I'm having lots of trouble with my angiomyolipomas, does that mean my LAM will be quite active too? There's not always an association between those two things, and so it's best to look at them independently. If it's other medical problems, then again, LAM is a fairly independent thing. So I think the answer to that, I'm not completely certain which active things are meant, but overall, I think LAM's usually fairly independent of other things. So I think that just needs assessing on its own. And if you have other medical problems, doesn't necessarily mean that you have to worry that your LAM's going to be more active, I think.
Brilliant. Thank you, Simon. Very last question, and then the grilling will end. Thank you. So the last question from Katie. Thank you, Katie. So I've had COVID twice. Can COVID impact or make worse LAM?
Okay, so it's a good question. So when we were, when COVID hit, we were very worried about what was going to happen to LAM patients if they got coronavirus infection. And we did a big survey actually in the UK and other places of people with LAM who'd had COVID infection, and it looked like they didn't do any worse than other people that got COVID who didn't have LAM. The other thing that we looked at was if you're on an mTOR inhibitor, did that make the COVID worse? And it was a fairly small survey. We didn't find lots of people, but there was no evidence that people with tuberous sclerosis or LAM did worse from the point of view of COVID, even if they're on an mTOR inhibitor. And so we recommend that people try and avoid getting COVID. We recommend that they keep up to date with their vaccinations. If you have other severe medical problems, then there are antiviral treatments that you can get if you contract COVID. If you have it in the first few days, there are other things that will that might help. But as a rule, well, on average, I suppose I should perhaps say, people with LAM don't seem to do any worse than other people with COVID, but it's still worth trying to avoid it. Nowadays, most of the patients I see have had coronavirus infection at least once. And most of them now that we've got the slightly milder strains and most people are vaccinated anyway, they tend to feel a bit unwell with it, but it seems to settle down. So try and avoid it, get vaccinated, but don't worry unduly about it, would be my advice.
Excellent. Thank you, Simon. Thank you for that question as well, Kate. This has been so helpful. I personally learned so much. It's been excellent. Thank you once again, Simon, for taking the time to come along. We're also thankful for all of your work and everyone at the LAM Center. And to everyone else, thank you very much for coming along. We really appreciate it. As I said, we do have more events coming thick and fast. We're trying to make it a little bit more varied as well, with some afternoon sessions for a few things coming up as well. So just keep an eye out. You always know we're always here. Keep an eye out on the TSC support line if you ever have any questions or anything like that. And hope you have a good night. So thank you all. Lovely to see everyone. Bye. Have a good night.
Thank you.
Right, thanks for the invitation.
Bye.
Bye.
Bye.